We're going to talk about pancreatic cancer some over the next couple sessions. It's a daunting task to try to, just talk about pancreatic cancer in of itself. So we'll try to break it up into several talks to make it more digestible. At the same time, probably, frankly, not a lot of you will do a lot of pancreatic cancer surgery as it's becoming more subspecialized. But hopefully some of you will, and certainly even if as general surgeons you're not directly doing a lot of these surgeries, you certainly need to know how to care for these patients and some of the nuances of it. My interest in pancreatic cancer dates back to my grandfather, who's pictured here with me during my med school era when I had more hair and less belly. But Orlando Chambers was one of the strongest individuals I ever knew. This guy was still working out on the farm, from 6 a.m. till dark, into his 90s. But a couple years after this picture was taken, developed obstructive jaundice and ultimately passed from pancreatic cancer. So it is not a super common cancer in our population. 11th most common cancer in United States males, 9th most common in United States females. But because of its high mortality, it is a high cause of cancer mortality. 4th most common cause of cancer death in both males and females. Risk factors, as with most things, there's at least some amount of a hereditary component. If you've got the baseline risk in the population, the American population of pancreatic cancer is about 9 out of 100,000. If you've got a first-degree relative with it, that jumps to 41 out of 100,000. 2 first-degree relatives, 58. And 3 first-degree relatives jump significantly to 288 out of 100,000. There are a number of familial cancer syndromes which have pancreatic cancer as a component. The most significant isn't real common, but if you've got Peutz-Jeghers syndrome, you've got a very high risk of pancreatic cancer, upwards of like 85% if you live into your 80s. The BRCA mutations, which we're most familiar with in relation to breast cancer, also do carry some increased risk of pancreatic cancer, as does hereditary non-polyposis colon cancer syndrome, which obviously HNPCC we're most familiar with in relation to colon cancer risk, but there is some increased risk of pancreatic cancer as well. And you can see a number of other hereditary contributors to pancreatic cancer risk. Most of the other risk factors for pancreatic cancer can kind of be understood in the setting of development of fatty infiltration in the pancreas or chronic inflammation in the pancreas with acinar cell damage. Chronic pancreatitis, certainly most commonly due to alcohol, leads to chronic inflammation, and with that you get overproliferation and inflammation, which can increase the risk, as you see here at the bottom. As we age, people who are less physically active and kind of develop metabolic syndrome are at risk for obesity, diabetes, and hyperlipidemia, all of which increase the risk of interlobular fatty infiltration and fatty pancreas, which increases the risk. The risk or the association of diabetes with pancreatic cancer is an interesting one, and one that you should know about, both due to the fat deposition in the pancreas that occurs that increases the risk of pancreatic cancer in diabetic patients, but the onset of pancreatic cancer can also cause diabetes. And so one of the common or something that we see not too uncommonly is a patient who isn't someone you would expect to develop diabetes. They've been maybe non-diabetic all their life, and now in their 60s or 70s they've got new onset diabetes without much change in their weight or other things. That's pancreatic cancer until proven otherwise. And interestingly, in some of those cases, even though we're taking the insulin producing organ out, or a portion of the insulin producing organ out, sometimes paradoxically those patients who have just developed diabetes late, along with the onset of the pancreatic cancer, their diabetes may get better and sometimes even resolve. Obviously, in most instances, when you take part of the pancreas out, your risk of diabetes increases, and that is a side effect of the surgery. But paradoxically, in some instances, the diabetes will get better. But worry about somebody who has a late onset or an atypical onset of diabetes and think pancreatic cancer until proven otherwise. um, Smoking and other carcinogens due to affecting proto-oncogenes such as KRAS also increases the risk. So you can see here's kind of a list of risk factors, but if you kind of understand the pathogenesis, you can kind of understand the risk factors as a whole. When we talk about pancreatic cancer, for the most part, we're talking about ductal adenocarcinoma or a variant of it, which is adenosquamous, which is uncommon. But 90% or so of pancreatic masses that we deal with are cancer. So the majority of the time when you see a mass in the pancreas, at least a solid mass, unlike in other areas of the body where cancers, you worry about it, but it's the minority, a solid mass in the pancreas, is kind of cancer until proven otherwise, and usually a ductal adenocarcinoma, unfortunately. There are other things which we see in the pancreas, though, other than ductal adenocarcinoma, which will get to. I think I got my slides out of order a little bit, but let me just back up for a second and say, in relation to ductal adenocarcinoma, it's seldom localized when we diagnose it. If you look at this, over 50% of the time, when somebody has the diagnosis of pancreatic cancer, it's already metastasized. So it just doesn't present with telltale signs which cause people to seek treatment early enough to catch it all too often, particularly in the body and tail. More so in the head, where patients become jaundiced, they'll seek treatment in time, and that's why the majority of the pancreatic cancers we're able to intervene upon are in the pancreatic head. Those in the body and tail are ones that, in order to get a cure, it's almost, we find it as a happy mistake with imaging that's done for some other reason before they become symptomatic. But over 50% of the time, it's already metastasized. The vast majority of other instances, it's locally advanced with regional lymph node positivity. And it's unusual. It's maybe only one time a year I see somebody who's truly got a localized stage 1 non-lymph node involved pancreatic cancer. There are other things that we see in the pancreas, though, and one of the more common of the least common masses that we see in the pancreas are intraductal papillary mucinous neoplasms. And I mention this at this point because IPMNs have a risk for the concurrent or subsequent development of pancreatic adenocarcinoma. And it's an important variant of adenocarcinoma to be aware of because it can develop years after the IPMN is first diagnosed, and it has a much better prognosis than most pancreatic cancer. If you look up here, overall 5-year survival, 10 to 15% with regular ductal adenocarcinoma of the pancreas. But if you have a ductal adenocarcinoma of the pancreas that's associated with an IPMN, you're looking at, upwards of 50% 5-year survival if that patient is treated aggressively. So I think it's important to recognize that the adenocarcinoma that develops with IPMNs is a little bit different than regular adenocarcinoma. And here's kind of a case example of that. As we go along, I'm going to try to just illustrate some of these points with cases from over the years. This was a lady initially from Bermuda, actually, who had immigrated to the United States, 75-year-old at the time that I met her. She presented with weight loss and anemia, got an upper endoscopy, and they saw extrinsic compression of the duodenum. You can see here the narrow duodenum. Subsequently got cross-sectional imaging, which showed this pretty fearsome looking pancreatic mass that you can see here, pretty big mass. And I presented this lady at tumor board, and at that time I was kind of the young buck. I think I think it did this case in 07, so I'd been back about 2 years. Gene Vassy was the senior surgeon that ran the tumor board then, and he crucified me very frequently at tumor board as being over aggressive and stuff. And he basically told me if I operated on this patient, it was malpractice and I was going to kill her. um, which I took into consideration. But we did subsequently take her to the operating room, and she, we knew that she had IPMN. We knew that she had adenocarcinoma having developed within it. Here you can see the mass. And we were able to resect this quite nicely. And you can see this is a resection plane that I'm pretty proud of. You can see the IVC here, the left renal vein. This gives you a good idea of the relationship of the vessels. Here's the portal vein, the SMV. Here's the transected pancreas here. So a pretty nice dissection. Here's what the specimen looks like. She had a bit of a pancreatic leak afterwards, kept her in the hospital, I think about 18 days, but then she went home and she did well thereafter. And this lady actually was completely cured from her cancer, lived another 12 years, and ultimately died from another condition, myelofibrosis, a few years ago. So, and this is an example of how I think, you should be, I think, appropriately aggressive, not over aggressive. We don't want to be, cowboys and over aggressive with these tumors. But as we'll talk about a little bit later on, I think you have to have a certain amount of surgical fortitude and courage to take care of these patients. And if you don't, you're probably ill-equipped to do it. And I think it's a balance sometimes, and I'm not always walked that balance right. But, appropriately aggressive, not a cowboy or a cowgirl, so to speak, hurting people, but also having the the courage and the surgical fortitude to help people that need big surgeries sometimes. IPMN, along with mucinous cystadenocarcinoma and a few others, are cystic. They fall into the family of cystic pancreatic tumors. This is really a topic in and of itself, so I'm going to defer that for a future conversation. We'll do that in a few weeks, where we'll talk about pancreatic cysts, including neoplastic cysts. But I mentioned the IPMNs here today specifically because of the adenocarcinomas, the solid cancers, which can develop within them. And looking, though, specifically now at ductal adenocarcinoma, and that's where we'll focus our emphasis on today and the next couple talks on. The head contains the majority of the ductal cells, so that's the most common site. It's also, again, where they present earliest. So most of the time, when we're dealing with adenocarcinoma that we can help patients with surgically, we're dealing with pancreatic head cancers. Less so in the body and less so in the tail. As we've said, pancreatic cancer, unfortunately, doesn't present early in most instances. How does it present when it presents? Most patients will have at least a vague abdominal pain, typically in the epigastric region. Very frequently, as you see here, about 60% will have anorexia or early satiety. Jaundice is what usually pushes people kind of over the fence into presenting. Most frequently you'll hear these patients talk about, well, hey, I was kind of feeling poorly for the last, few weeks or few months. And then my eyes turned yellow, my skin turned yellow, and that gets people's attention. And that's usually when they come in and present. Other things they'll notice is the darkened urine, the lightened stools, all reflective of what's going on with the bile duct being obstructed. Weight loss, kind of a bad sign, but present in the majority of patients for multifactorial reasons. One is, if you have a cancer, the cancer cells kind of start to steal your metabolism a little bit. But also in the case of pancreatic cancer, certainly the effects of jaundice and the pancreatic exocrine insufficiency, which occurs, also causes weight loss. And it's very frequent that these patients will come in malnourished and have to undergo prehabilitation with an emphasis on nutrition prior to becoming appropriate operative candidates. Again, diabetes, very frequent. I don't know if 97% in all. In this series, it was 97%. I don't know if it's quite that high in my experience, but certainly very frequently seen. Back pain is a particularly bad sign. Those patients are usually unresectable body or tail masses. But all too often, pain and the other symptoms with a subjective component are vague enough that a diagnosis is difficult, at least early on. Well, when you have a patient that's a concern, how do you work them up? This is from the NCCN guidelines. Basically, a good triple phase CT scan is the diagnostic modality of choice. MRI in some instances is helpful. We don't like MRI, and I think Fernando and I are on the same page with this. The problem with MRI and pancreatic cancer is you have some amount of motion artifact, which really blurs the relationship with the surrounding vessels, which for us as surgeons is one of the key things that we look at, the relationship of the tumor to the portal vein, to the superior mesenteric vein, to the superior mesenteric artery, to the branches of the celiac artery is key, and MRI is just not very good at it. So a good triple phase contrasted CT is the diagnostic modality of choice. You ultimately do chest, abdomen, and pelvis, to appropriately stage the patient. And then to make the diagnosis, the vast majority of patients will get an EUS as that facilitates FNA. Also, certainly want to get your baseline labs, very important to get liver function tests, and also CA19-9 levels. And we'll talk about each of these a little bit. Here's just for basically completeness sake, the sensitivities and specificities, but CT scans the go-to study. And then as far as tumor markers, I don't care about CEA, I don't care about anything else. CA19-9 is really all you need to order. Well, let's talk a little bit about CA19-9 because I think it's, if anything, increasing in importance. Carbohydrate antigen or CA19-9 of importance. It's not present in all patients. Patients who lack Lewis body antigens, which is about 10% of the population, won't produce CA19-9. So it's not a 100% thing, but when it is present, it can be helpful in trends in a number of ways. If it's elevated, it worries you more. An elevated CA19-9 in and of itself does not make the diagnosis of pancreatic cancer. There are other things that can elevate it. Most importantly, it can be elevated just with jaundice due to choledocholithiasis or something. So if you have a jaundice patient and the CA19-9 is really high, take note of it, but it may just be due to the jaundice. Can also be elevated and is helpful as a marker in cholangiocarcinoma. It was actually originally described as a tumor marker with colon cancer. We know that CEA has a better performance than does CA19-9, so we don't use it much there anymore, but it can be elevated in that setting as well, also in some instances of esophageal cancer and HCC. But most important, I think, to recognize as far as false positives is obstructive jaundice, pancreatitis, and cirrhosis can all, in and of themselves, elevate the CA19-9. How do we use it? Well, if it's elevated preoperatively and after the biliary system is drained, and then it decreases after surgery, that's a good sign. If I have somebody who comes back several weeks after their pancreatic duodenectomy or their distal pancreatectomy, and their CA19-9 was in the hundreds preoperatively and it's less than 35 postoperatively, I feel pretty good. If it's still in the hundreds, I don't feel so good. We're also going to see that it's after neoadjuvant therapy for borderline or locally advanced pancreatic cancer, it along with the imaging findings is predictive of whether you should move forward with the subsequent surgery or not, and we'll show some data on that. When you're following patients long term, one of the things we follow in addition to their clinical course and their imaging is the CA19-9, and if it starts to go up, you worry about it. Now, I've had some instances where the CA19-9 is really high and there's no imaging correlation. The oncologist won't treat that typically. The standard of care is not to treat just an elevation of CA19-9, but it certainly prompts you to look for it. Interestingly, a baseline CA19-9 level, it used to be used sometimes as a delineator of whether patients should receive aggressive treatment or not. With modern chemotherapy and surgical principles, that is no longer appropriate. Here's one study out of the British Journal of Surgery showing why that's the case. And if you look here, you have here the CA19-9 was on the lower side at the upper part of the yellow here. Here it's on the higher side. Interestingly, you can see that there's no correlation with the patients who are able to get an R0 resection after neoadjuvant treatment. So it is, however, predictor of mortality. So if you have somebody, their CA19-9, and you diagnose them with pancreatic cancer, and after you drain the biliary system, before you drain the biliary system, it may just be high due to the obstructive jaundice, okay? But so after you've drained the biliary system and their LFTs have normalized or at least come close to it, then you recheck that CA19-9. If it's still really high, yes, it does increase the chance that they will overall die ultimately from pancreatic cancer. But interestingly, it does not seem to predict with accuracy whether or not you can ultimately resect the patients, which the two kind of seem contradictory. I don't know how to completely explain that. I guess the point I would make is that don't write somebody off just because of a high CA19-9 level with modern chemotherapy regimens that we're able to give them because the data doesn't support it. So once you get your CT scans, your chest, abdominal, pelvic CT scans, and you've got the diagnosis confirmed with EUS, because EUS, frankly, it doesn't really help me that much in regards to telling me what the mass looks like or whether it invades the vein or the artery. I pay attention to all of that, but the real reason for getting the EUS is to get an FNA to confirm the diagnosis. And we're going to talk about that in a few moments, and the importance of that in the vast majority of instances. But if they don't have metastatic disease on clinical exam or on CT, and you've got the confirmation, then what do? Do you proceed with surgery, or do you give the patient neoadjuvant treatment? This is with resectable disease. So later on, we're going to talk about patients that have borderline resectable disease and locally invasive disease, or locally advanced disease, the term that's usually used. And what does that mean, and what are those categorizations? It, for the most part, means they've got local invasion of vessels. There are some other definitions. We're going to talk about that at the next lecture, give a lot of time to that because I think it's really important. But for purposes of today's discussion, let's talk about those patients who do not appear to have local invasion, those who appear resectable. Upfront surgery versus neoadjuvant therapy. The pancreatic cancer is such a deadly cancer, and in the past the outcomes have been so bad. There is an understanding, and I think it's mostly appropriate, that pancreatic cancer is from very early on a systemic disease. And so that argues, and many authorities now argue, for giving neoadjuvant therapy up front, even with resectable disease, just because the outcomes of pancreatic cancer historically have been so poor. That is not yet standard of care, though, and I would argue, and I'm going to share a little bit of data, that I think the enthusiasm for neoadjuvant therapy with resectable disease is not always well-founded. And I like how the NCCN puts it. They recommend consideration of surgery up front in the absence of high-risk features. So if you've got a large tumor, if you've got large lymph nodes, a particularly high CA19-9, or your symptoms are particularly severe, then those are ones that maybe you should lean toward giving that patient neoadjuvant treatment prior to proceeding to surgery. Outside of that, per NCCN guidelines, it's still very reasonable to proceed with upfront surgery. And I think that's important because, particularly amongst academic circles, I think at times we as surgeons who are still advocating for upfront surgery without neoadjuvant treatment are kind of regarded as Neanderthals who, just want to operate on patients and stuff. And I think at times perhaps we're guilty of that, but I think in other instances, I think we perhaps, there are some downsides to neoadjuvant treatment in resectable disease. And let's go through some of these nuances. Well, what are the advantages potentially of preoperative chemotherapy? It can downstage the patient, certainly, and that is particularly important with borderline resectable. And I think all of us that do these surgeries are in agreement that with borderline resectable or locally advanced cancer, those patients should get neoadjuvant treatment up front. There's no question, because it does have the possibility of downstaging. It addresses the systemic spread up front. What typically kills patients with pancreatic cancer is not the local effects of the disease, it's the metastatic spread. And so this addresses the systemic spread up front, because upwards of, at least historically, upwards of 40% of patients who get pancreatectomies do not subsequently get adjuvant chemotherapy because of complications. I think we're doing better than that now. I think at times there's a little bit of a delay in chemotherapy, but I think I would look back over my last 10 years or so, I would say at least 85% of my patients are are going on to get the neoadjuvant treatment. But the thinking is if you give it, I meant to say adjuvant treatment after resection. But addressing the systemic spread up front, certainly there's merit to that consideration as an advantage for preoperative chemotherapy. You know, when you do the surgery, do you kind of decrease the perfusion of the tumor cells and make them less responsive to the chemotherapy? This is more of a hypothetical thing, but maybe. Decreased risk of tumor cell shedding at the time of surgery. I don't know. I think, again, a little bit more hypothetical and questionable. Sterilization of regional lymph nodes has a potential advantage because one of the most common ways that the pancreatic cancer will recur after you've done an R0 resection is still local recurrence in the retroperitoneum. And that is probably from regional lymph nodes. And would that be decreased? And I think it can be in some instances with pre-op chemotherapy. And then kind of a little bit nihilistic, but, you know, just looking at particularly in the past when Whipple's had a very high or had a significantly high mortality rate and extremely high morbidity rate, do you kind of naturally select out patients for this somewhat morbid surgery by just, you know, ultimately operating on those that have responded? I think that the two first of these are the most significant or the most valid of these. On the flip side, I think, you know, there are some potential disadvantages of preoperative chemo, and this doesn't get quite as much press. For me, most significant is that not all pancreatic cancers respond to chemotherapy. And for those non-responders that are resectable, I think by giving them neoadjuvant treatment, you're potentially missing a window of time when you could get that cancer out and give the patient a better long-term survival. I think also at times the complications of chemotherapy are downplayed, particularly at tumor board, at least in the past. I don't attend it as frequently as I should now, but I used to attend on a weekly basis. And you know, I got weary at times of, you know, being portrayed as, you know, surgeons that were subjecting, you know, patients to these awful surgeries and all these complications. Well, these chemotherapy regimens are no walk in the park. And the patients can get pretty beat up from chemotherapy just like they can from surgery, but I think at times that gets less press. At times it's also a disadvantage because to give somebody chemotherapy, you've got to have a tissue diagnosis. And sometimes the tissue diagnosis can be tough to get. With EUS, that's much less of an issue than it used to be. But there are times when EUS can't be done or EUS, for whatever reason, isn't able to confirm the diagnosis. If those patients have, you know, a mechanical obstruction from a pancreatic mass, it's a very reasonable thing to proceed with surgery in that setting, because even if it is, let's say, chronic pancreatitis or maybe, you know, a neuroendocrine tumor or something that's not what, you know, we're thinking initially, you know, you're still giving them the right treatment because the treatment is the same for any pancreatic mass that's creating, for example, obstruction of the bile duct and stuff. The treatment for that, whether it's chronic pancreatitis or ductal adenocarcinoma of the pancreas or neuroendocrine tumor or, you know, or whatever, a Whipple's the right surgery for that. Chemotherapy, not the case. You know, neuroendocrine tumor, for example, receives very different treatment than does an adenocarcinoma. So you have to have a tissue diagnosis before any preoperative chemotherapy, and the same is not true for surgical intervention. There are, you know, it's very appropriate to do the same surgery for chronic pancreatitis, for example, as it is for pancreatic cancer. Now let's talk a little bit more about this, though, this tissue diagnosis and stuff, because, you know, I don't want to be accused of following the so-called inappropriate law of the instrument. You know, if all you have is a hammer, everything looks like a nail. So I'm a surgeon that does Whipples, so, you know, we're going to treat all these patients with Whipples. Obviously, that's not a good mindset. Having said that, if you look at, now we're talking solid again, cystic, we're talking about that on a different day. We're not talking about cystic masses here. But if we're talking about solid pancreatic masses that are creating symptoms, so they're creating obstructive jaundice, or they're creating pain, or they're creating pancreatic exocrine insufficiency, what can cause that? Pancreatic cancer overwhelmingly, pancreatic neuroendocrine tumors, non-autoimmune chronic pancreatitis, solid pseudopapillary tumors. All of these patients benefit from surgery. And this is the vast majority of them. Metastatic cancer, arguable. Trivia question, I have seen one instance of this. What's the most common cancer that metastasizes to the pancreas? It's actually renal cell cancer, followed by melanoma. But you can argue that surgery is a benefit in all of these patients. So I don't need a tissue diagnosis necessarily to proceed with operative intervention. Two noteworthy exceptions. And this is why we really need to get EUS, as in with biopsy in most patients if possible. Lymphoma and autoimmune pancreatitis. And these are big pitfalls to doing surgery up front without a tissue diagnosis. So we need to be aware of both of these. So let's give these a little bit of discussion. This is a case I did back in 2011. A lady that came over to me from Lancaster, Scott Johnson referred this patient to me. And we actually got an EUS in this lady, and it came back most consistent with neuroendocrine tumor. It was a formidable case, as you can see here, invading the liver up here some and stuff. Here's the specimen, had to take a little liver off with it and stuff. Difficult case. Then the path came back as pancreatic lymphoma, which the treatment for that's not surgery. Typically, it's chemotherapy. So boy, and she had a pancreatic leak. Took a while to get her better. Fortunately, she got better. I still see her on a yearly basis today. This was an instance of pancreatic lymphoma where really would have liked to just give her chemotherapy and it would have melted away. Fortunately, she had ultimately a good outcome. And we had tried to do the right thing, but for whatever reason, the cytopathologist just miscalled the lymphoma as a neuroendocrine tumor. But so you don't want to operate on pancreatic lymphoma if you can avoid it. So try to recognize it. The best way is, again, get an EUS and get an FNA that hopefully will be more helpful than the one was in this instance. But there are some things, some tip-offs that might lead you to suspect a lymphoma. Lymphoma is very rare in the pancreas, but it does occur. But if you see a large mass like this one without jaundice, so it's just kind of pushing on the bile duct but not creating obstruction, that's kind of classic for lymphoma. Or if there's lymphadenopathy out of proportion to the tumor mass. Usually pancreatic cancer spread to the lymph nodes. They're kind of small, hard lymph nodes. They're not these big, fatty, plump things like you get with lymphoma. Having said that, you certainly can see larger lymph nodes of pancreatic cancer. But in instances where maybe you have a large mass without jaundice, if you have extensive lymphadenopathy, and for some reason you can't get an EUS with an FNA, this might be one of the rare instances where the risk-benefit ratio would argue for a percutaneous biopsy. We don't like percutaneous biopsies for the most part because they risk tumor seeding, and that's a very real thing. So for the most part, it's contraindicated to do percutaneous image-guided biopsies of pancreatic masses. But if for some reason, an EUS is much better because you're going through the viscera and not creating a long needle track for seeding. But it might be worth it if it's something that looks like a pancreatic lymphoma. Or in other instances, do it laparoscopically or robotically or surgically potentially. Obviously, the downside there is you kind of muddy up the fields. Or perhaps if I had another case like this and stuff, what I might do is go in, do the exploration, do the mobilization, and do some true cut biopsies while we're in the OR and while we can still back out. Problem is the pathologist is probably going to equivocate and not give you a direct answer in too many of those instances. But this is something to look out for. Autoimmune pancreatitis is something else to look out for if you're considering operating without a tissue diagnosis. This is a lady. This was actually the CT of Mahir Bakru, the GI doc who does a lot of EUS and stuff for us. This was his administrative assistant's mother who came to me with this kind of fearsome looking pancreatic mass. But we got an EUS, Mahir had done an EUS on her, and it just showed inflammatory changes only. And so, recognizing that, we got in that there's a potential that, this could be something else. And one of those things is autoimmune pancreatitis. We got an IgG4 level on her, and that was significantly elevated. She got a course of steroids, and the thing got better. I'll skip ahead here. Here's where she started. Here's where she ended up at, just after a couple weeks of steroids. So autoimmune pancreatitis is uncommon. It's only 5% of chronic pancreatitis cases. When we talk about chronic pancreatitis, the majority of the time we're talking about alcohol-related chronic pancreatitis. And if you see a patient and they've got biliary obstruction from chronic pancreatitis, those patients need surgery. You know, they need a Whipple. But if they've got autoimmune pancreatitis, different story. And if you just give somebody a couple weeks of steroids, those patients get better. The etiology of this disease process is poorly understood. It's an IgG4 positive lymphoplasmacytic infiltration, which looks like this under the microscope. And basically, this inflammatory infiltrating process causes significant sclerosis. And autoimmune pancreatitis is just part of the IgG4 related family of diseases, if you will. These include variants of retroperitoneal fibrosis, the condition of sclerosing cholecystitis, sclerosing cholangitis, variants of pulmonary fibrosis and pulmonary masses, mediastinal fibrosis, nephritis, and salivary gland inflammatory issues. Sometimes these can be, you can have several of these occurring together. More often they occur independently, but the pathophysiology is similar in each of these disease instances. And probably the most important thing with all of these is these patients can have a dramatic response to steroids and don't need procedural interventions. And in this case, this patient also had, when we were first working her up, we got the CT scan of the chest abdomen. She had a pulmonary mass as well. And she got steroids, pancreas got better, pulmonary mass got better. So she had both pulmonary and pancreatic involvement from autoimmune pancreatitis. So how do you make this diagnosis? Well, again, if you see something like this, before you go to the operating room, you're usually going to confirm the tissue diagnosis. And this is one of the reasons it's important. But you get an EUS and it's a negative biopsy, could be a sampling error. You still have to think about cancer. But if you get that EUS and it has a negative biopsy, you should always check an IgG4 level. IgG4, and it's hard to order. The verbiage you have to put in is immunoglobulin subtype, and then you have to go in and select IgG4. If you ever need to order, just ask me. I've ordered it wrong enough times. I can for sure get you the right way now. But if you have a negative biopsy, get an IgG4 level. If it's significantly elevated, you got to think about autoimmune pancreatitis. Now, a difficulty is that 7 to 10% of pancreatic cancer cases can have at least a mild elevation of the IgG4 level. So you have to keep that in mind. Just because the IgG4 level is above normal doesn't necessarily mean you're dealing with autoimmune pancreatitis instead of pancreatic cancer. But it probably is worth delaying any surgical intervention or chemotherapy for giving 2 weeks of prednisone and seeing what happens. And if the mass melts away after 2 weeks of prednisone, or their jaundice gets better or something, then you've got your answer. If you don't, okay, geez, is this a pancreatic cancer that also just happens to have an IgG4 level? In most instances, the IgG4 level elevation with pancreatic cancer is mild, and the higher levels is pretty much diagnostic. As you can see here, 99% specificity with higher levels of IgG4. But non-diagnostic biopsy, get an IgG4 level. If it's elevated, consider a couple weeks of steroids and then reevaluation so that you don't end up taking a patient with autoimmune pancreatitis to the OR. I've seen about a half dozen autoimmune pancreatitis cases over the last 15 or 20 years. I've been fortunate to diagnose all of them preoperatively and not make the mistake of going to the operating room. Sadly, I have hurt a patient, killed a patient actually, by not recognizing a sclerosing IgG4 related cholecystitis case. This was a case that I did that Fernando and I did a few years ago. My case, my call, he was just helping me. But what threw us off was a number of things. One is I didn't even know about sclerosing cholecystitis back then. The other is you got this huge gallstone here, and this lady that has this fearsome looking gallbladder mass. tried biopsying it. That was indeterminate, but you can't really biopsy the gallbladder very well. So we took her to surgery, and because this area invaded the right hepatic artery, we did a formal right hepatectomy. Pretty big surgery. Went well initially, but tragically, she did not ultimately prove to have adequate liver reserve, and she died from fulminant liver failure about 3 weeks after surgery. Uh, you know, as I was talking to her family and stuff after she passed away. I obviously felt terrible, but at least took some comfort in that we had no other choice because this was such a terrible cancer, obviously. And the initial report from our pathologist was that it was indeed consistent with cancer, but they sent it off for a second opinion, and like 4 weeks after surgery, 1 week after the lady died, I got this report back from the University of Michigan, said this was sclerosing cholecystitis. So basically, a lady died from complications from a surgery that, if we had recognized it for what it was, given her steroids, I think she still would have needed surgery ultimately because she had a sick gallbladder from the stone, but she sure probably would not have needed a right hepatectomy, and even just doing like a partial cholecystectomy might have been better. So a case that still haunts me to this day. So we got to be careful, and you need to secure the diagnosis whenever you can. And if the diagnosis is not, clear on biopsy, consider or recognize the potential for this weird variant of disease processes that IgG4 can cause. On the flip side of things, here's another patient that we weren't able to make the diagnosis with, as several FNAs were negative. The patient is significantly symptomatic from this large pancreatic mass. So, what are you going to do? We took the patient to surgery. IgG4 level was negative. Formidable mass, as you can see here. Here's what it looked like on the final specimen. Here's our dissection plane. This is probably one of the more impressive dissections I've done here. The anatomy is kind of just worth a look. Here's your superior mesenteric vein, your splenic vein, portal vein. Here's basically your entire celiac system, all skeletonized, splenic artery, celiac trunk, hepatic arteries, right and left. So this was I think this ended up being like a 13-hour case. And the guy had an undifferentiated cancer. Poor prognosis. The guy lived 1.5 years, though, of which 1 year was good. And, the last 6 months were tough with palliative care, but we gave the guy some time. So I guess the message I would have would be the same one that Mike Seiss made in his comments when we presented our FRSS data at the American Association of Surgery and Trauma back in 2005, and it was subsequently published in the Journal of Trauma in 2006. And for me, Dr. Seiss's comments, they're kind of just summarizes what I think has to be our mentality as surgeons, that we have to be ready to act boldly, to stand, deliver, and answer for our results. So there's going to be times when you have to, operate on a case like this if you're going to help somebody, maybe in the absence of uncertainty, but do so only while being, as careful as you can that is the right thing. In relation to pancreatic cancer, because of bad outcomes in the past and stuff, they're developed, and I think we're getting past this now, but they're developed for a while, particularly in the 90s and early 2000s, but I think it carries over still some to this day, of kind of a nihilism in regards to the diagnosis of pancreatic cancer and there being no hope, and don't even bother referring the patients to the surgeons because they're just going to put them through some morbid procedure that's going to kill them sooner and stuff. And Dr. Telemonte and his colleagues at Northwestern, I think, kind of well exposed this in this publication in the Annals of Surgery back in 2007, where they looked at the National Cancer Database between 1995 and 2004, and they just specifically looked at stage 1 pancreatic cancers. Okay, so these are patients with no lymph node involvement, no evidence of local invasion, early stage pancreatic cancer. And they saw that only about less than 30% of patients underwent surgery. 71% received no surgery for, a very potentially curable pancreatic cancer, and almost 40% were not even offered surgery, were never referred to surgeons. And then they tracked the outcomes of those patients, and not surprisingly, obviously the patients that were not offered surgery, did more poorly. And 5-year survival, 25% in the patients who received surgery, 70% 1-year survival. So I think a nice exposure of, I think, the inappropriateness of a nihilistic approach to surgery in the saying we can help patients, a selected number of patients with these surgeries, and surgeons should be involved in patients that have pancreatic cancer, because the patients that get long-term survival are those that get surgery. And the conclusion of this study, I think well-founded, was all resectable pancreatic tumors should have surgical consultation, as operative intervention represents the only currently potential curative modality. So having said that, looking at resectable disease, what do you do? Do you do surgery or do you do neoadjuvant treatment? No definitive guidelines are present. I think the NCCN ones, which are based somewhat on anecdote, somewhat on literature, make sense. I think they're good ones to consider. And certainly, again, as we'll talk about next time, borderline resectable patients should get neoadjuvant treatment. Well, where's the data at? What is the data, though, with neoadjuvant treatment in patients with resectable pancreatic cancer? Not a lot out there. The problem is, and it's frustrating, and as I reacquainted myself with this literature over the weekend, I got again frustrated, is the vast majority of the literature out there are papers like this one, looking at FOLFIRINOX versus gemcitabine and surgery and stuff for resectable and borderline resectable pancreatic cancer. Here again, neoadjuvant treatment in patients with resectable and borderline resectable. There's multiple studies out there where, in order to accrue enough patients, they include both borderline and resectable patients. And obviously that muddies the water, because when you see benefit from neoadjuvant treatment, then is it because of the borderline resectable patients only, or are truly the resectable patients getting benefit? And you just can't answer that from most of these studies because of the way they've been conducted. Hot off the press, just published this month, Dutch study, 12 centers in Europe, so multi-center randomized prospective phase 2 trial looking at neoadjuvant FOLFIRINOX versus upfront surgery for just resectable pancreatic head cancer. Okay, so this is what we want to see. Just resectables, not looking at the borderline resectables, looking at that as a different patient population. And what they found was that across the board, actually the upfront surgery and the neoadjuvant, no significant difference. If anything, slightly favored upfront surgery. And so the conclusion, median overall survival, 25 months in the neoadjuvant group compared with 38.5 months in upfront surgery. No survival benefit with neoadjuvant therapy. And this is, I think, the best study out there now. And so, I certainly think there is a place for neoadjuvant consideration in patients with resectable pancreatic cancer, but I take exception to people stating that it's a standard of care. It is not. And if anything, I think with this most recent study, you can argue that unless there's confounding factors, patients with resectable pancreatic cancers are probably better off receiving surgery up front. Again, borderline resectable, different animal. We're going to talk about that next time. All of those patients, in my opinion, should get neoadjuvant treatment. We'll talk about that next time. What do you do after you resect the patients? They get adjuvant treatment afterwards, which is usually going to be FOLFIRINOX or gemabraxane, and we'll talk about that more in a future talk. In the last couple of minutes that we've got here, let's just talk a little bit about the surgery for pancreatic cancer. We talk about the head, body, and tail of the pancreas, but in regards to pancreatic surgery, you're essentially talking about right-sided lesions or left-sided lesions, based upon where they fall in relation to the pancreatic neck, which is the area overlying the mesenteric vessels. You know, if you've got tumors to the left of the mesenteric vessels or overlying them, then you try to do a distal pancreatectomy. If it's to the right, then they need a pancreatic duodenectomy or a Whipple resection. So when I talk to patients about, you know, pancreatic cancer surgery, I tend to just talk about right versus left-sided. For the most part, because the majority of patients that we can help with pancreatic cancer are pancreatic head masses, this is mostly a discussion of pancreatic duodenectomy. But let's speak just briefly about, you know, distal pancreatic splenectomies. So if you have left-sided tumors, the majority of those, unfortunately, are going to be unresectable because they present late. But if you catch them, then these are patients who are benefited by an in-block distal pancreatectomy with splenectomy. There is no place for preserving the spleen here. The spleen needs to come out. So these patients, they get triple vaccination preoperatively, and they get an in-block pancreatic splenectomy. I think the majority of these can be done minimally invasively. I do them laparoscopically. Certainly they can be done robotically as well. The majority of the time, though, when we're talking about pancreatic cancer surgery, we're talking about this area. And so we're talking about pancreatic duodenectomy. You know, pancreatic duodenectomy or the Whipple resection has, you know, kind of a rich history. Despite the name of the Whipple procedure did not start with Dr. Whipple. Others way back to Trendelenburg in the 1800s, and most significantly Couliavilla and Couch thereafter, as well as Dr. Herschel had done previous iterations of pancreatic duodenectomy. But it was with the work of Alan O. Whipple who kind of codified the approach to pancreatic duodenectomy, initially in a two-stage operation. And that's the reason the procedure kind of bears his name eponymously. Interestingly, I'll show my age a little bit. During my time at LA County, an emeritus professor in infectious disease there was none other than Alan O. Whipple's son-in-law. So I felt that I touched history when I interacted with him, so to speak. But, you know, hard to believe that, you know, this giant of surgery, you know, frankly, didn't live all that long ago. I think Dr. Whipple and a number of others who made advances leading up to the 1990s, and then really pancreatic duodenectomy came into, I think, its modern iteration due to the work at two centers in particular, Johns Hopkins University, where Dr. John Cameron and Charles Yao started to publish good data in the 1990s showing that, hey, you can actually do Whipples without killing people at a high rate. And they published, I remember what was unheard of at that time, which was a series of 100 Whipples without a mortality that caused our jaw to drop when we reviewed it in Journal Club. And I think this was subsequently followed by the work of Doug Evans and his team at MD Anderson. And then he subsequently went on to Wisconsin, but I think his most meaningful professional work was done at MD Anderson, where he really kind of codified the steps of pancreatic duodenectomy. And it's through his work that I kind of developed my approach to this in kind of a clockwise fashion, where you start out with a Cattell-Brosh maneuver, mobilizing the right colon and the terminal ileum up to expose the retroperitoneum, and then extending that up into your Coker maneuver, mobilizing the duodenum, and then you just keep working on up into your performance of your cholecystectomy and your portal dissection. You then transect either the stomach or the duodenum, depending on whether you're going to preserve the pylorus or not, and then reflect everything off to the right side. Then go up into the left upper quadrant and transect the jejunum just distal to its takeoff from the duodenum. Then return back to the retroperitoneum, transect the pancreas, and then as the last step and the most critical step oncologically, the retroperitoneal takedown or the retroperitoneal transection. You know, and then this is, you know, the first half of the surgery or the resection phase, and then obviously you have to put things together in the reconstructive phase. This is what it looks like schematically. This is the critical area oncologically, and you got to devote a lot of time to this. Taking down that connective tissue and the soft tissues and the fibrolymphatic tissues, I guess would be a better way to call it, between the uncinate process of the pancreas and the SMA. And this is, you can't really typically get the SMV this far out of the way, but the point is it's behind kind of the SMV. And this is what you want to see at the end. Again, here's your superior mesenteric artery here, skeletonized on its anterior right side and posterior aspects, and a nice clean dissection here. Otherwise, I probably got a little overkill on skeletonizing the IVC here. It's probably not necessary to go quite that far, but it is necessary to get this margin taken down immediately adjacent to the superior mesenteric artery. And, this is an art in doing this, and I think that this is potentially an advantage of the robotic approach, in that you can get a better view of this area without having to stand on your head quite so much as we do to do it from an open approach. This is what your specimen will look like at the end. And your goal is obviously to have a R0 resection, which is both a grossly negative and a histologically negative resection margin at all margins, not just the retroperitoneal margin, all margins obviously. R1 is grossly negative but histologically positive. Certainly we don't like this as much as R0. Interestingly, when you look at the literature, sometimes it's hard to distinguish in most series in the outcomes between R0 and R1. So the day is not lost if you have microscopic positivity at your margin. Certainly I feel better and sleep better on patients that have an R0 resection, but you can still get long-term survival even with R1 resections. And most of the literature, although it flies in the face of seemingly common sense, it's actually hard to demonstrate that R1 is much inferior to R0 in most of the literature. R2, that is a failure. If you're leaving gross cancer behind, you probably shouldn't have been there, and certainly if you didn't give the patient neoadjuvant treatment beforehand, shame on you, because you should have. And so in those few instances where I've left tumor behind, I feel really bad about that. Having said that, at times in the OR, you just can't tell, and I remember a case in particular that Fernando and I were doing maybe about 6-7 years ago, and we just felt miserable about this thing because it was just awful, and we felt like we were carving through cancer to get through all this, despite the imaging seeming to show that it was resectable, and we just felt like crap at the end of the case. But we pressed on because we were there, we were committed, and actually the guy ended up having a small tumor, and it was all just desmoplasm and pancreatitis. So you just can't tell when you're in the OR sometimes. But R2 is not good. R0 is the best. R1, okay, it's the day's not lost necessarily. Then the reconstructive phase, there's a number of different ways to do this. The classic way is what's pictured here, where you have an end-to-side pancreatic ojejunostomy. You don't want to do end-to-end. The studies have shown that pretty clearly. You want to plug it into the side of the jejunum, and then downstream you do your biliary anastomosis, and then downstream, where the most variability is, you anastomose either in side-to-side fashion to the duodenum if you're doing pylorus preserving, or to the stomach if you're doing an antrectomy along with the specimen, which tends to be my preference. What are your goals in performing the surgery? To get negative margins, a clean in-block resection, obviously minimize blood loss, and to maintain GI function. It takes a while to do this. MD Anderson, where they do a large volume, their average is about 7.5 hours. I'm slower than that. It's probably about 8.5 hours for me. Variations of the procedure, which are reasonable. It's reasonable to preserve the pylorus, although I think the advantages have probably been overstated. You can do it, and then anastomoses in different ways. There's a lot of different articles out there how to do your pancreatic anastomosis, etc. Not strong data, and there's a number of different ways to skin the cat, so to speak, in regards to that. Whether to place tubes and drains or not, again, controversial. Many people will argue not for doing them. I tend to do them because when you need them, you really need them, and then when you don't, you just get them out early. Just a couple more points and then we'll stop. We're going to talk in a separate lecture on complications of pancreatic duodenectomy, but one of the most vexing is delayed gastric emptying. And there are some tips you can do when you do your reconstruction that help minimize the risk of delayed gastric emptying. One is that you want to do an anticolic anastomosis of the stomach. You don't want to go behind the colon. So retrocolic has a higher risk of delayed gastric emptying, so you want to do anticolic. Something that I found very helpful and has decreased my personal anecdotal rate of gastric emptying issues is making sure you have an axial orientation. So if you have your cut off, where am I at here? If you're cut off stomach, where am I at? Looks like this to the side. At times it'll, particularly if you're preserving the pylorus, they'll be off to the side. In those instances, make it more axial by going to the side of the stomach to keep it in line with basically the spine, and it tends to empty better. If you leave the pylorus, you have a higher risk of delayed gastric emptying. Do a large anastomosis, that helps it empty better. Things which are best avoided: total pancreatectomy, unless you absolutely have to for like a multifocal tumor or IPMN, don't do it. A lot of the problems with those cases. Routine vascular resections to be more aggressive, falling out of favor. Don't want to do that unless you have to. Extended lymphadenectomies. You want to get a good number of lymph nodes, but you don't want to go outside of the routine lymph node planes. Laparoscopic Whipples didn't really pan out. Had inferior outcomes in a number of ways, so that fell out of favor. Robotics, I think Dr. Aguila elegantly presented several months ago. That robotic Whipple is, I think, the future for this procedure. And Dr. John Cameron, when he came and spoke at Columbus Surgical, said, you're going to be doing this surgery in the next 10 years. Robotic is the way to go, and I would have to agree with that. And I applaud Dr. Aguila for bringing that to the Mount Carmel. I'm too old of a dog to learn that new trick. I'm not going to get over the learning curve, but I think I still have something to offer because I think that the data is still not clear that the outcomes are inferior. I think as robotic surgeons become better and better at this procedure, I think in the future they will be, and I think just like with robotic prostatectomy, I think robotic Whipples will be the standard in the future. And I think that provides an opportunity for those of you that train in our program. If you want to do hepatobiliary pancreatic surgery in the future, it is very difficult to come out of a program like Mount Carmel and get a position in a surgeon fellowship or a hepatobiliary surgical fellowship. Those are very research-heavy fellowships. If you haven't done a load of research, you're not going to get those positions. However, what I think positions you could get would be a minimally invasive fellowship and go somewhere where they have an emphasis on doing robotic Whipples. I think that's the backdoor way to establish a pancreatic cancer surgery practice in the future. I think a downside, though, of robotics in the future is a diminishing ability to do open surgery well. If you're doing, all robotics, I don't think there's going to be as good of an open surgeon, and I don't know how to overcome that downside, if you will. But I think here we're good at least still, and that's another reason I do them open too, and still persist as I think for the training purposes. When you look at volume outcomes relationship, and we're going to stop with this, certainly people that do things more tend to get better outcomes. Having said that, the most critical when this was looked at appears to actually be the experience of the surgeon over their career. So it's not necessarily how many you're doing a year, but that you're experienced over a career. And so how do you do this right? I think it's to break into practice with someone who's done it a lot, learn, from them in addition to the training that you've received before, and then go on and I think deliver excellent care. So we'll stop there, and I'll be happy to take any questions or comments from anybody.
Thank you, Dr. Chambers. You had mentioned earlier in the presentation that the mortality rate with the adenocarcinoma associated with the IPMN was far better for the patient.
Yeah, the outcomes are better. The long-term survival is better. Yes.
what is there a mechanism that's known for why that is? Is it because there's better lead time on these patients and we know something's going
That's
on,
a
or is
great
that
question. That's a great question. There are some of the variants, and I've seen this once. For those of you that helped me take care of Jimmy Browning, he was just in hospital recently for other stuff. Some of them are variants like colloid adenocarcinomas, which just kind of like medullary breast cancer, just has a better prognosis because it's just histologically not as aggressive. Having said that, it's seen even when it's just a routine ductal adenocarcinoma. I don't have an answer for you. It's a great question. Certainly, some of it is maybe that you're making the diagnosis sooner because of the presence of the IPMN component. I don't know that it's just that, though. I don't know.
Thank you.
Anybody else? Okay, well, I know we've run over a little bit, so we'll be respectful of everybody's time. We'll start next time and looking at, I think, the stages of care and the importance of patient selection. Thank you all for your attention.